Hi, my name is Catriona Rogash. I am a speech pathologist at Goulburn Valley Health in Shepparton. I work with adults on the acute and rehabilitation wards. I'd like to thank the Hume Regional Integrated Cancer Service for the opportunity to present on this quality initiative and for the viewers for their attention. So the project at which I'm going to be speaking about today is titled Improving Emergency Laryngectomy Management for Patients Attending a Regional Victorian Health Service. I'd like to acknowledge all those who contributed over the course of the project. Again, special mention to the Hume Regional Integrated Cancer Service, who provided an improvement grant to us in 2020 that saw this project to fruition. To Amanda Jean White and Emma McDonald, co-authors, and who provided their expertise to me as project lead. So firstly, what is a larynx? A larynx is our voice box. It's the part that sits at the front of the neck and is made up of various ligaments, muscles and cartilage, as depicted in the diagram. And they move to allow air into our lungs when we breathe, to make sounds for voice, for speech, and to protect our airway and lungs during swallowing. So laryngeal cancer is the most common cancer type of all head and neck cancers. It is also the 56th most common tumour, and accounting for approximately 160,000 cases per year worldwide. A total laryngectomy is a surgical procedure used in the advanced stages of laryngeal cancer, which is the removal of all the structures of the larynx, and then the windpipe or our trachea is sewn to the front of the neck, and a hole is made called the stoma that allows the person to breathe. So this is just a nice image depicting the anatomical changes after a total laryngectomy. The key take-home message here is that after a total laryngectomy, the image on the right, the food pipe and the windpipe are no longer connected. The person cannot receive any air through their mouth or nose. They can only receive air through the stoma in the neck. This is why laryngectomy patients are often referred to as neck breathers. Total laryngectomies have a major impact on a person's life. It changes the way they speak, breathe, look, and occasionally swallowing. However, with adequate training and social supports, these issues can be well managed and the person can live a relatively typical life. So once the stoma is created, artificial devices can be inserted into the stoma for different purposes, such as a heat and moisture exchanger or button. So the HME, as it's called, helps reduce mucus buildup and coughing by humidifying and filtering the air which the person breathes through the stoma. Additionally, to create voice, given the vocal folds have been removed, voice prosthesis is inserted through the stoma into a hole called the tracheoesophageal puncture between the windpipe and the food pipe, and this vibrates to make voice. And the image on the bottom right is just an example of someone receiving stoma care where the mucus has built up inside the trachea. These devices may become blocked, displaced, or leak, leading to significant and potentially life-threatening harm such as respiratory distress. So what led to the project? So total laryngectomies are generally performed at specialist metropolitan hospitals, and regional laryngectomy patients continue to receive the majority of their care by that service, such as medical reviews, yearly changes of their voice prosthesis and allied health, and so on. So typically, in relation to GV health, laryngectomies are a rare and complex patient demographic, with the majority of medical and nursing staff having limited to no previous experience treating these patients. At the time of the project, there were 3 laryngectomy patients living in the Goulburn Valley region. Historically, they would present here to GV health in the emergency department for emergency airway distress and require timely, effective, and coordinated care. The laryngectomy emergencies were commonly managed by relying on individually acquired skills or lessons learned from previous errors. How relying on this method isn't sustainable and led to suboptimal medical management with potentially life-threatening consequences. Also at GB Health, we do not have a ear, nose and throat physician that specialises in laryngectomies based on campus. It is outsourced from Melbourne on a monthly basis, so getting that specialist medical support is limited and incurred extra cost to the hospital to transfer these patients to their metropolitan service for the specialist care they require. So despite previous speech pathology endeavours to upskill and educate the emergency department, urgent support was needed to better manage laryngectomies in these events. So as mentioned, our overall aim was to improve laryngectomy management within the GB Health Emergency Department. This was completed over a 3-month time frame, so a day per week. So a desktop review and benchmarking was completed with 10 Victorian metropolitan and 4 regional services in regards to their clinical practice guidelines and hospital-related processes. It was identified that the Austin Hospital CPG was appropriate for adaptation to meet GB Health's requirements, and approval was sought and obtained from Austin Health Speech Pathology Department. A survey of knowledge and confidence and skills levels of the GB Health ED staff in laryngectomy care was completed. It consisted of 6 questions relating to various components of laryngectomy management, from identifying a laryngectomy from a tracheostomy, providing stoma care, and events relating to emergency airway management. It was distributed over an 8-week period over AM and PM shifts to ED, nursing, and medical staff. The results really confirmed that there was significant variability in confidence and knowledge levels of these staff that would be providing care to these patients. Overall, knowledge gaps were identified, and this would be addressed during the course of the project. This led to the development of a localised and comprehensive laryngectomy clinical practice guideline. To address the knowledge gaps identified during the survey, the CPG comprised of video links, step-by-step instructions for various components of laryngectomy care, such as inserting catheters into the tracheoesophageal puncture site, stoma care, and so on, and other resources that would be applicable to nursing and medical staff. It also consisted of care across the inpatient stay at GB Health, from the emergency admission to the ward and to being discharged. The document was reviewed by various GB Health stakeholders, from allied health and medical, nursing, across the continuum of care, and to ensure it reflected current best practice and our processes here at GB Health. And collectively, the changes were made, and the CPG was released onto our hospital document management portal, which is accessible by all GB Health staff. The project led to the establishment of the medical alert. So this went through several committees and worked closely with Health Information Services and the IT department in its approval. The alerts can be added to any patient's file, and from this, an auto-generated flag is displayed on the patient's information platforms that can be seen by any GB Health staff, and it flashes the title Laryngectomy Neck Breather to act as a alert that they have an altered airway. And the speech pathology department added this to all pre-existing known community laryngectomies in the region. Once the alert has been added to the patient's file, an auto-generated page to the acute speech pathology department is triggered anytime that patient presents to ED or is transferred into the hospital from another organisation. The speech pathology input is not always required in relation to all situations, such as respiratory distress. However, as speech pathologists have specialist knowledge in laryngectomies and can support locating and utilizing the CPG, aiding in voice prosthesis changes and other events as that. So limitations to the project were low response rate to the survey. So the coronavirus pandemic meant that contributing members had conflicting and changing priorities, which decelerated the speed at which inputs were given. And as previously mentioned, we do not have regular ENT support that could guide medical management, ensure that the CPG and other components with best practice. So where to from here? So there were focuses that were identified and work has already begun in this space. So one being the development of an online learning package that would be added to our education portal that would be mandatory for all ED and CCU staff to complete annually. Also, the department has worked on slides that can be added into our basic life support package that is organisational wide and required for all all GV health staff to complete annually. So we also have that in place. Might be considering nurse champions in laryngectomies. However, with shift work and rare presentations, we might go 12 months without seeing a laryngectomy. This may mean limited opportunities for a nurse to feel proficient and confident in all aspects of laryngectomy care. Further resources are required. So as you can see on the top left picture, creating laryngectomy kits, which will include all the equipment that would be required in an emergency airway event, as all appropriate resources that would be applicable to staff, and this would be provided to the ED department, CCU, and one within the speech pathology department. And then further data collection regarding changes in confidence and knowledge of medical and nursing staff would be beneficial to complete as well. So thank you so much again for viewing my presentation, and I look forward to answering any questions you may have. Thank you.